All right, guys, welcome back. And today we're going to finish up the endocrinology section, and we're going to be talking about the other endocrine quote-unquote emergencies that we might have. And there are some that are involved with other glands that we'll talk about briefly. It's not really as bad as but again, usually your pancreatic emergencies are the ones we deal with, the high and low blood sugars. All right, but there are some other ones out there that they love to throw in on the old National Registry test. Thyroid gland, hyperthyroidism or thyroid tychosis, and also called Graves' disease. These are the patients that got kind of the buggy eye appearance. That's kind of a telltale sign of the Graves' disease. And I guess I should probably bring up a picture of somebody like that, because that is kind of actually an important thing there. Let's see here, new tab. Let's see here, Graves' disease. This is how they look. Yeah, there we go. That's her. This is a kind of a telltale sign of somebody with Graves' disease that has hyperthyroidism. And by the way, they're usually pretty thin folk. They're usually, because your thyroid controls metabolism, so that it controls metabolism. That's why you have the issues that you have where you're seeing that. And hyperthyroidism, and again, the hypothyroidism is the exact opposite. Usually these are your more plump individuals, and when they got midexema is the inadequate levels of thyroid hormone, and it causes structural and functional changes. Okay, so the Graves' disease, again, 6 times more common in women than men. Kind of an important point. And it's autoimmune in origin. Usually something just it produces too much thyroid hormone. And again, these guys get insomnic really easy. Their temperature control, they have very poor heat tolerance. And they can have a massive appetite no matter how much they eat. They can eat like 3 peanut butter pies and, still be hungry, and their blood sugar still be, 70. And, they'll weigh 110 pounds soaking wet. These people are just, right? Again, they can cause protruding of the eyeballs, so that's an exophthalmophilus is the name of that. And interaction with the autoantibodies, it often produces a goiter. So this is an example of, again, the eyes bugging out there. And again, when the thyroid gland actually grows bigger, that's a goiter. And as you can probably guess, you think that tritium it will put a little bit of pressure on the trachea, but like if you're going to intubate her, you might have a little bit of difficulty with that. Usually, by the way, goiter, they'll usually surgically remove the excess tissue. Kind of depends on, sometimes they just let it go. Now, your thyroid tychosis, again, this is the thyroid storm. Guys, severe physiological stress usually, and it's fatal within 48 hours if untreated. That's the thing. High fever, irritability. Again, it turns their metabolism up to nuts, okay? They're going to be tachycardic. There'll be hypotensive, vomiting, diarrhea from this, okay? Really bad, and this needs to get to the hospital immediately. So that thyroid storm, again, extremely bad. Again, now your hypothyroidism usually is congenital. Both sexes are affected. By the way, diabetics are notoriously known to have the hypothyroidism along with their diabetes. Just wanted to throw that one out there for you, okay? Again, the midexema is a thickening of the connective tissues, and they actually can go into a coma from this. They'll become hypothermic, a stuporous state, and they can be failure if respiratory depression does occur, okay? So yes, you can die from not having enough thyroxine in your system, all right? By the way, I can tell you that one of the biggest issues I do have with mine is the cold intolerance. And actually, it's pretty bad. Classic appearance, again, unemotional, puffy face. They'll have thinned hair. Again, when your thyroids are not right, by the way, a lot of hair loss or again, so this is one of the things that you can have. And you got to have pale skin that feels like a dough type feeling to it. Again, this is the edematous skin type. If you actually look at my legs, guys, they kind of look like that. Again, the patient with midexema requires, if they're in a coma from that, they're going to require ventilatory support. You really need to intubate these folks. Now, We're going to go to the adrenal glands and understand that Cushing syndrome is something that is very different from Cushing's triad. Cushing's syndrome involves excessive adrenocortical activity, where Cushing's triad has to do with increased intracranial pressure in the brain. Now, Addison's disease, again, it's caused by a deficient adrenocortical activity. So again, these two guys are opposite. Cushing's is too much and Addison's is too little. Okay. Again, usually affects the middle-aged person, which is Cushing syndrome. It's long-term exposure to glucosteroids. Women usually get this more than men. They get weight gain, trunker body, head, neck, and they get that moon-faced appearance to them. Now, what does that moon face look like? There you go. That's kind of what you're looking at. All right. Oops, sorry. The skin changes are common, and mood swings or impaired memory. That's another one. If you're starting to see this, then you're getting this type of look. So again, these patients usually have a higher incidence of cardiovascular disease, including hypertension and stroke, by the way. And again, be prepared when your skin prep. The skin is very fragile, so make sure that you use good technique on this. And remember, it's really thin skin, so be careful. So your Addison's disease, these are the guys that have a lot of steroid production. They fail to produce an adequate amount of steroids, and it's a 90% due to autoimmune disease. And again, it's usually hereditary in response. And again, they get into crisis where such as infections or trauma. And again, they can affect all the adrenal hormones and cause hyperadrenalism, hypoadrenalism. So that's the problem with the congenital adrenal hyperplasia. Okay, so if it's not working the way that it's supposed to, Waterhouse Friedman lock syndrome, WFS, again, severe adrenalitis. Okay, so you get an overwhelming bacterial infection caused by massive adrenal hemorrhage. Okay, so basically, and again, it stops producing the materials needed. Remember, it does have to do with your sympathetic system. So again, your adrenal glands make an important point here. So again, the major disturbance is your water and electrolyte imbalances with your Addison's disease. Okay, watch your fluids with these guys. Okay, sometimes they might need a whole bunch. Sometimes they can overload very quickly. Okay, they usually have a decreased appetite, weight loss, hyperpigmentation of the skin and mucous membranes. Okay, again, it can cause electrolyte imbalances as well. So maintain your ABCs, keep a good, as it screws up your electrolytes, you got to keep looking at that heart monitor, okay? And get them somewhere where we can get those blood levels, and then also check their blood glucose levels, because those can be thrown off when you got a patient with Addison's disease, okay? Again, hypoglycemia is the biggest threat probably. Be aggressive in fluid resuscitation. My little caveat to that would be, it's okay to do that so long as you make sure you don't fluid overload them, because that is one big problem that you can have with Addison's disease. Again, follow your local protocols with that, okay? So those are the emergencies involving the endocrine system. And obviously, we don't deal with a lot of them. The sugar one is probably the biggest one we deal with. And if they go into a thyroid storm, and by the way, you need to be getting moving on a thyroid storm patient. Okay. And a lot of times we miss that. They're really tachycardic. They're going for it. And when they really need to be, they need to be at the hospital. And again, that's because the thyroid has gone just berserk. Okay. Don't forget about check their blood glucose. That's a standard of care now. Check the glucose. And again, start getting a good history on these patients. This is a medical emergency, and these are history-driven events. Okay. So with that being said, don't forget, by the way, DKAs, HHNKs, the difference between those two, and again, the long-term monitoring, and again, any diabetic emergency, stabilize the airway, oxygenate, get the IV, and stabilize the blood sugar as best as you can, okay? And no, we don't want to give insulin in the field. We really don't, okay? It's not that it's a big deal, but it's something that we shouldn't be doing in an emergency setting, okay? You guys take care, and I'll see you guys on the next one.